Good evening, guys. This is discussion D for you, and it's the last one for the night. We're going to discuss end of life decision making when it comes to cancer patients. It's made by the oncologist mainly. So here we go. Let's get into it, shall we? The article explores how end of life decisions for terminally ill cancer patients are often influenced more by their oncologist's treatment habits than by the patient's personal preferences. A study by Rutgers Health published in Cancer found that oncologists often have the final say in whether patients continue aggressive treatments like chemotherapy, even if they're in their final days. Clinical guidelines recommended stopping such treatment when they offer no benefit, but many oncologists continue based on routine rather than individualized patient goals. Give me 1 second. Researchers analyzed national Medicare data from over 17,000 patients who died of breast, lung, or colorectal or prostate cancer between 2012 and 2017. They discovered that treatment patterns varied significantly based on the oncologist, suggesting decisions may reflect physician tendencies more than patient-centered care. This research raises important questions about how to align end-of-life care with what patients truly want. This seems closely tied to your interest in communication strategies and patient autonomy. Would you like to explore how these findings connect to patients and to person-centered care? Or person-centered planning? Or systematic healthcare reforms? The findings from this study have profound implications for patient-centered care, especially when it comes to end-of-life decisions. Erosions of autonomy. If treatment decisions are swayed more by physician habits than patient preferences, the patient's voice is diminished during one of the most critical phases of care. Misalignment with goals of care. Continuing aggressive treatments like chemotherapy in the final days of life can contradict a patient's goals for comfort and dignity or time with family. Especially when those innovations offer no real benefit. Trust and communication gaps. Patient and their families may assume that ongoing treatment is necessary or beneficial when it may reflect a physician's uh, default practice rather than shared decision-making process. Systematic barriers to personalization. This highlights the need to reevaluate how medical systems incentivize or normalize aggressive innovation and interventions, and to better support providers in having nonsense value-based discussions. In your work around end-of-life planning and communication, this really underscores the importance of interventions like structured advanced care planning, palliative care consults and decision-making aids that facilitate a genuine dialogue. Would you be interested in exploring models that encourage more consistent implementation of these strategies, like serious illness conversations or the use of value-based care checklists in oncology? Serious illness conversations are structured, compassionate discussions between clinicians and patients facing life-limiting conditions. The goal is to align medical care with what matters most to the patient their values, goals, and preferences, especially when time may be limited. These conversations typically include understanding the patient's uh, perspective. What what do they know about their condition? How much do they want to know? Sharing prognosis in a sensitive, honest way. Exploring values. What are their hopes, fears, and what gives their life meaning? Clarifying trade offs. How much are they willing to go through for the possibility of more time? Okay. Next page. Documenting and honoring preferences. Ensuring care plans reflect the patient's priorities. The serious illness conversation guide developed by Ada, Adeline Labs and partners offers a step-by-step framework to support these decisions. It is not just about medical decisions, it's about dignity, clarity, and connection. Giving your focus on communication strategies and autonomy at end of life care. This model seems like a powerful tool. Would you like to explore how it's being implemented in oncology and palliative care setting, or how it might be adapted for caregivers and self-directed models? Serious illnesses, serious illness conversations often offer a host of benefits that ripple across patients, families, clinicians, and the healthcare system. Improved alignment with patient values. These conversations help ensure that care reflects what truly matters to the patient, whether that's maximizing time at home, avoiding uh, burden burdensome treatments, or uh, preserving dignity. Better quality of life. Patients who engage in these discussions often experience less anxiety, receive fewer unwanted interventions, and report greater peace of mind. Reduced unnecessary hospitalizations. Studies show that early early values based conversations can lead to fewer ICU admissions and emergency visits in the final months of life. Stronger relationships and trust. Open conversation or open compassion dialogue fosters deeper connections between patients, families, and clinicians, building trust and reducing conflict during difficult decisions. Clarity for caregivers. Families are more likely to feel confident and less burdened when they understand the patient's wishes, which can ease emotional strain and reduce decision regret. System-wide benefits. Health systems see improved patient satisfaction, more appropriate, uh, reduce resource use, and better documentation of care preferences. This model seems especially aligned with your focus on autonomy and communication in end of life care. Would you like to explore how these conversations are being integrated into oncology or self directed care frameworks? There, there's some fascinating work happening around adapting them for diverse cultural and cognitive contexts. Two, serious illness conversations can significantly reduce healthcare costs without compromising care quality. Here's how. Okay, fewer high costs interventions. Patients who engage in these conversations are less likely to receive aggressive treatments like ICU stays or late stage chemotherapy that don't align with their goals. Earlier planning, smarter resource use. When preferences are known in advance, care teams can avoid unnecessary hospitalizations and focus on comfort oriented care, which tends to be less costly. Documented savings. A study using Medicare data found that patients who had a serious illness conversation incurred about $4,000 less in healthcare expenses during the last 3 months of life compared to those who didn't. Better alignment, less waste when care matches what patients actually want. There's less spending on interventions that offer little benefit and more investments in services like hospice or home care that improve quality of life. Okay. Interestingly, this cost effectiveness uh, dovetails with your interest in systematic reform. It suggests that honoring patients' autonomy isn't just ethically sound, it is financially responsible too. Would you like to explore how these savings could support broader implication in Medicaid or self-directed care models that could be a powerful leveler for change? Serious illness conversations can be a powerful leveler for shaping healthcare policies because they sit at the intersection of ethics, economics, and patient-centered care. Here's how they can influence policy. Categorize cattailing value-based care models. By aligning treatments with patient goals, these conversations reduce unnecessary interventions and interventions. This support this supports policy shifts toward value over volume, rewarding quality outcomes rather than quantity of service. Informing reimbursement structures. Policymakers can use evidence from these conversations to justify Medicare or Medicaid reimbursements for advanced care planning, palliative consultants, or even caregiver support services. Driving documentation standards. Okay, widespread use of serious illness conversations and encourages better documentation for patients' preferences, which can inform electronic health record or EHR policies, and interoperability standards. Reducing discrepancies when adapted for diverse populations. These conversations can help address inequalities in end-of-life care, prompting policies that support culturally sensitive communication, training, and access to interpreters. Shaping legislation. Data showing improved outcomes and cost savings can influence laws that mandate or incentivize advanced care planning, like requiring hospitals to offer these conversations during serious diagnosis. This dovetails beautifully with your interest in systematic reform and autonomy. Would you like to explore how states are integrating these conversations into Medicaid waivers or self-directed care models? There's some fascinating moratoriums that space it out. Okay, guys, so that's it for tonight. I'll see everybody tomorrow for shows. Till then, Gator Wellness. Take care, folks. Have a good evening.